attempt to emphasize on a few points in clinical cardiology which may be useful for your clinical exams or the practicals. So we'll be discussing about heart sounds and murmurs. So whenever you talk of a murmur, it's important to describe them under certain headings. Okay, the first thing is the timing of the murmur, whether it's a systolic or a diastolic murmur, shape of the murmur, crescendo murmur, decrescendo murmur, or a crescendo decrescendo murmur, location of the murmur, that's the area where it is maximally heard, then the radiation of the murmur, pitch of the murmur. It may be either a high-pitched murmur, low-pitched murmur, or a medium-pitched murmur. Then the quality of the murmur. Sometimes it's very helpful in the diagnosis. There's a rough and rumbling mid-diastolic murmur, which is quite harsh, or a soft blowing murmur of aortic regurgitation. So the quality of murmur is important. Then you should always grade the murmur. Systolic murmurs are graded into 6 grades. So that's how you describe a murmur, with 6 points. So you should not just say murmur present in mitral area. So you should describe the murmur, the timing of the murmur, the quality of the murmur, the shape of the murmur, the location or the point of maximal intensity of the murmur. All this should be described. Then we'll go to what is known as the location of the murmur. So if you see the evidence-based medicine clinical cardiology of Steve Walk, he has a unique way of describing the murmurs. So the murmurs are either described as apical, basal, apico-basal. So what is the apex of the heart? So generally you take the left third intercostal space parasternally as the cutoff point. So anything above is a basal murmur, anything below is a apical murmur. So it's as though the aorta and the pulmonary arteries act like a tree trunk. So the base is above, the apex is below in cardiology. So certain murmurs are found predominantly at the base of the heart. So the base of the heart, as I told you, is above the left third parasternal intercostal space. So the aortic and pulmonary murmurs are in the base of the heart, whereas the mitral murmurs, the tricuspid murmurs, are in the apex of the heart. So there are some murmurs which radiate apico-basally, that is, they are found even in the apex and the base. So they are called apico-basal murmurs, characteristic of VSD. It's very widely heard. So that is the classification of murmurs as per Steve Walk: apical murmurs, basal murmurs, apico-basal murmurs. So now we will go to the most important case in clinical cardiology, the mitral regurgitation. As we all know, in mitral regurgitation, usually due to rheumatic heart disease, you get a holosystolic murmur or a pansystolic murmur in the mitral area, which radiates to the axilla and the tip of the scapula. It's high frequency murmur. It's best heard at the apex, loudest at the apex. So this is characteristic of the mitral regurgitation murmur. So more than the murmur, it's the associated findings which help in the making a diagnosis of mitral regurgitation and the etiology of mitral regurgitation. So in chronic MR, as per Steve Walk's evidence-based clinical medicine, S1 is normal in 75% of the patients, loud in 12% of the cases, and soft in 12% of the cases. So you can easily say the S1 is normal. There is a physiological splitting of the second heart sound in 50% of the patients with mitral regurgitation. The S3 is common, especially in chronic MR, in 90% of the patients. With severe MR especially, S3 is common. And apex is enlarged and laterally displaced. You have a forcible apical impulse in mitral regurgitation. And if the MR is quite severe, you can have a left parasternal pulsations, which is due to the enlarged left atrium and associated tricuspid regurgitation. So the pulse is hyperdynamic. These are the characteristics of chronic mitral regurgitation. Next, you should try to differentiate the moderate and mild from severe MR. So what are the points which help in the making a diagnosis of severe MR? So the intensity of the murmur correlates with the severity of mitral regurgitation. Suppose the murmur is grade 3, 4, then it is quite a severe MR. That's the characteristic of mitral regurgitation. Then, as I told you, that late systolic left parasternal impulse due to the left atrium enlargement, that also helps in telling the severity of the MR. Though some examiners say that S3 is associated with severity, the evidence available from most studies doesn't show any correlation between the severity of MR and presence of S3. Next important thing is to differentiate acute from chronic mitral regurgitation. So acute mitral regurgitation, the patient is hemodynamically unstable. So it has happened suddenly. The mitral regurgitation has happened suddenly. There is a tachycardia. You get an S4. So in chronic mitral regurgitation, you get S3, whereas in acute mitral regurgitation, you get a S4. Is a sick tachycardic tachypneic patient. There may be a short systolic murmur and presence of S4, such as acute mitral regurgitation. So in chronic mitral regurgitation, the heart has time to compensate. So you have a enlarged heart, you have a pansystolic murmur, you have a S3. All the typical findings, whatever we have described, is typical of chronic MR. So another important cause of mitral regurgitation is papillary muscle dysfunction. So in papillary muscle dysfunction, you get a murmur which is transient. There is pain, patient has an associated chest pain, and the murmur is holosystolic, mid-systolic, or late systolic. So it's usually in acute setting. The papillary muscles support the chordae tendineae, and in ischemic heart disease, when there is a papillary muscle rupture, the mitral valve starts leaking. So that is papillary muscle dysfunction causing a MR. It may be musical also. That's one characteristic. Another important diagnosis regarding the mitral area is the mitral valve prolapse. So mitral valve prolapse, or the Barlow syndrome, click murmur syndrome, it's also called the click murmur syndrome, is typical in young ladies. It's most of the time asymptomatic, detected accidentally. So if the murmur of MEP is loudest and is at the apex, and it's musical in character. I was telling you, character helps in the diagnosis of the etiology of mitral regurgitation many a times. So the murmur is late systolic because the mitral valve leaflets are well supported by the chordae tendineae and competent during the early systole. So the murmur is late systolic. The regurgitation happens late in systole. Clicks are loudest at the apex or the left sternal margin and occur in mid or late systole. The murmur follows the click. And what is the cause of the click? So the sudden deceleration of the billowing mitral leaflet as it prolapses into the left atrial cavity produces the click. So that is the mechanism of click in mitral valve prolapse. So that is mitral valve prolapse. Next, you should know the response of these murmurs, systolic murmur in the mitral area to maneuvers. So what are the important maneuvers? So in mitral valve prolapse, what happens is these maneuvers change the timing of the clicks and murmur. So reduction in venous return by straining during Valsalva or moving from squatting to standing position causes the ventricular chamber to become smaller and the mitral leaflets prolapse earlier during systole, thus moving the click closer to S1 and making the murmur longer. So what happens when the venous return to the heart is reduced is the ventricular chambers become smaller. So when does this happen? During the straining phase of Valsalva or while standing. So there is the reduced venous return to the heart. So what does that do in MVP? It changes the timing of the murmur. Contrast this with Hocum. So even in Hocum you get a systolic murmur in the mitral area or the left parasternal region. There will be a double apical impulse. But what does the maneuvers do in Hocum? So whenever there is a decrease in the venous return to the heart during the straining phase of Valsalva or the standing position, so the ventricular chamber again becomes smaller. So what happens in Hocum is the intensity of the murmurs increases when there is reduced venous return to the heart, because this increases the obstruction. It's a dynamic obstruction in Hocum. So it causes a what is known as the because it's a dynamic obstruction, and when the ventricular chamber becomes small, the mitral valve leaflet and the septum come closer. So whatever maneuvers reduce the venous return to the heart increases the intensity of murmurs. In MVP it is the timing of murmurs, whereas in Hocum it is the intensity of murmurs that change. So it's in Hocum it's a harsh murmur, it's a systolic murmur, harsh, and it's loudest at the apex and in the left sternal margin, and it's a sort of dynamic obstruction. So how to differentiate a fixed obstruction, that is aortic stenosis, from Hocum? So Valsalva in the strain down phase of the Valsalva, as we have understood earlier, increases the intensity of dynamic obstruction like Hocum, whereas the intensity of the murmur reduces in aortic stenosis. And squatting increases the murmur of aortic stenosis and decreases the murmur of Hocum. Standing does the exact opposite. So fixed obstruction is aortic stenosis. It's fixed. Aortic stenosis either due to rheumatic heart disease or due to sclerotic valve, degenerative valve. The obstruction is fixed, whereas in Hocum it's a dynamic obstruction. So you do maneuvers like straining phase of Valsalva, standing position. So both of that reduce the venous return to the heart. This increases the intensity of murmurs in Hocum, whereas the fixed obstruction, aortic stenosis, stenotic murmur reduces in intensity. That's how the maneuvers help. So next you have the systolic murmur of mitral regurgitation. How do maneuvers help in that? So there are methods to increase the afterload. So the hand grip, whenever you do the forced hand grip, there is an increased afterload. Or if you tie a BP cuff to both the arms and inflate the cuff, so there is again increased afterload. So what does this increased afterload do to the murmur of mitral regurgitation? So what happens is the systolic murmur intensifies, intensity increases with maneuvers, and that increases the probability of the murmur being due to mitral regurgitation. So as we have seen, the maneuvers are quite useful in differentiating mitral valve prolapse. Hocum, when mitral valve prolapse, they change the timing of the murmurs. In Hocum, they change the intensity of the murmurs, and afterload helps in making a diagnosis. Increasing afterload helps in the diagnosis of making a clinical diagnosis of mitral regurgitation. So another important question in the exams is mechanism of murmurs. So again, mechanism of murmurs is due to turbulence, that is increased blood velocity, wide narrowed valves or incompetent leaking valves, abnormal connections, vibration of loose structures such as a myxoma or a blood clot. When the diameter of the vessel is increased or decreased, all these causes murmurs. The most important is whenever the valve is narrowed or leaking. That is the most important cause of murmurs. Then another important question in the exams is the grading of the murmurs. So systolic murmurs are graded as per Levin and Freeman, Levine and Freeman grading of systolic murmurs. So grade 1 murmurs, grade 2, grade 3 up to grade 6 systolic murmurs are graded up to 6. So the most common murmurs you see in exams are grade 3 or 4. Okay, either you hear the murmur quite easily. If there is a thrill, it is a grade 4 by 6 murmur. If there is no thrill, it is grade 3 by 6 systolic murmur. So just for theoretical understanding, grade 1 murmur is so faint it can be heard with special effort. The room should be made quiet and you should focus, concentrate to hear a grade 1 murmur. In grade 2, murmur is faint but is easily audible. Grade 3 is moderately loud. Grade 4, I said, is associated with a thrill. Grade 5 murmur is very loud and audible with one edge of the stethoscope touching the chest wall. Grade 6 murmur is so loud that the stethoscope is just removed from contact with the chest wall, but you can hear the murmur. So that is systolic grading of murmurs as per Levin and Freeman, 6 grades. So diastolic murmurs are graded as per Ames grading. There are 4 grades of diastolic murmur. So grade 1 is very soft, grade 2 is soft, grade 3 is loud, and grade 4 is loud with a thrill. So another important question in the exams is radiation versus conduction. So what is radiation? Radiation is due to the non-cardiac structures, the chest wall, the muscles, the ribs, all that, and conduction is through the anatomical continuity. So the aorta continues to the neck. So that is due to the anatomical continuation is conduction. Radiation is usually due to the non-cardiac structures. In radiation, the intensity increases with distance, and in conduction, intensity remains the same or decreases with distance. So how do you make it out? That is by the inching method. You make out the intensity. So you decide whether it is radiation or conduction. So the classical example of radiation is the mitral regurgitation murmur, which is radiated to the axilla. Okay, mitral regurgitation murmur is radiated to the axilla, whereas the aortic stenotic murmur is conducted to the neck, direct continuity. The aorta goes directly to the neck, divides into the internal and external carotid artery, and it's direct anatomical continuity to the neck. So that is conduction. Radiation is by the structures, other structures such as the ribs, the chest wall. So that conducts the murmur. So that transmits the murmur, and we call it as radiation. So radiation and conduction. So what are the murmurs best heard with the bell of the stethoscope? So it's usually the low intensity murmurs, the murmurs of the mid-diastolic murmur of mitral stenosis, tricuspid stenosis, third heart sound, fourth heart sound, pericardial knock are best heard with the bell of the stethoscope. The low-pitched murmurs heard with the bell of the stethoscope. So all the other murmurs are best heard with the diaphragm, the systolic murmur of MR, TR, AR. Diastolic murmur of aortic regurgitation is best heard with the diaphragm. So there you have what are known as innocent murmurs, where there is no organic pathology in the heart. They are just innocent murmurs. So the soft, short, systolic murmurs, which are sensitive to position, these are the characteristics of the innocent murmurs. They are heard in a very small area. They are sweet, soft murmurs heard in a small area, usually in the pulmonary area. So what are the examples of innocent murmurs? The mammary shuffle, which it's an innocent murmur, pulmonary systolic murmur, which I described, vibratory systolic murmurs called as Stills murmur. All these are innocent murmurs. So next important question, which is quite difficult in the exams, is pulsus paradoxus. So how do we check pulsus paradoxus? It is by the blood pressure apparatus and by tying the blood pressure cuff. Though it is called as pulsus paradoxus, it's not a paradox. It is a exaggeration of the normal fall in systolic blood pressure during inspiration. So how do you check for pulsus paradoxus? So you tie the blood pressure cup and start deflating. So when you hear the Korotkov sounds for the first time, that's the first reference point. That's usually in expiration. Then again you start hearing the Korotkov sounds with both phases of respiration, predominantly in the inspiration. So that is the second point. So the difference between the two is normally not more than 3 to 4 millimeters. So if it is more than 10 millimeters, you call it as pulsus paradoxus. So what is 3 to 4 normally? The BP, the hearing of Korotkov sounds during expiration and during inspiration expiration, the difference is normally between 3 to 4. When it goes up to 10, you call it as pulsus paradoxus. So you get it in COPD, pericardial tamponade, and constrictive pericarditis. Next you have the pulsus alternans. So again you can easily feel the strong amplitude pulse and the weak amplitude pulse, the volume of the pulse, what we call. So another way to confirm that is again tying the BP cuff and hearing for the Korotkov sound. So suddenly at one phase there is a doubling of the Korotkov sounds. What happens is initially you hear only the strong beats. When you further lower the blood pressure, you start hearing the weak beats. So there is a doubling of Korotkov sounds, which is characteristically seen in left ventricular failure. So next is the measurement of the JVP. That's a very crucial point in the exams. So you should always carry two scales to the exam, two small scales, measuring scales should be carried. You should identify the highest point of the jugular venous pulsations in the neck. The position of the patient should be at 30 degrees to the bed. The back of the patient should be at 30 degrees for better visualization. You should shine a torch. You don't see the vein pulsating. It's the skin over the vein that pulsates. That's what you should look for. You don't see the vein as such pulsating. It's the skin over the veins that is where you find the pulsations. There are a lot of questions regarding the waves. So A wave is due to atrial contraction and V wave is due to the venous filling. The X and Y descents are more prominent, better seen than the positive waves. Okay, so then the measurement of the JVP. How do you use the two scales? So one scale is kept at the upper level of the pulsation. Another scale is kept vertically at the level at the sternal angle. Another scale is horizontal at the upper level of pulsation. This vertical distance is the JVP. So that you should remember. It is 3 to 4 millimeters normally. The vertical distance between the highest point of pulsations and the sternal angle, that vertical distance is the JVP, and normally less than 3 to 4 centimeters. So measurement of JVP is very important. Another important thing is you put the patient in different positions while doing the clinical examination of the heart. So the examiner is usually observing how you are examining the patient. It's a short case, so you'll have about 15 minutes. While taking exams for the next patient, you will be seeing how you will be examining the cardiovascular system in the next bed. So if you put in various positions, we know that you are well versed in cardiac examination. So Normally, what you do, you go from area to area, the mitral area, the tricuspid area, the pulmonary area, the aortic area, neo-aortic area. So there you you palpate, you hear the sounds, you describe the S1, you describe the S2, describe the murmurs. So sometimes it is very difficult to palpate for the apex in the normal sleeping position. So at that time you put the patient in left lateral position and you can feel the apex. So there the quality of the apical impulse is well made out. That's one left lateral position. And when you are suspecting aortic regurgitation, you make the patient sit and lean forward to hear the early diastolic murmur of aortic regurgitation. That's mandatory. Before doing that, you should never comment there is no early suppose you have a wide pulse pressure, the systolic BP is 180, diastolic blood pressure is 0, so there is a wide pulse pressure. So you should put the patient, you should make the patient lean forward and here in the neo-aortic area with the diaphragm for the early diastolic murmur of aortic regurgitation. Then we know that the student is quite well versed in the hemodynamics, knows the basics of cardiology, and it's very important. Maneuvers and the positioning of the patient is seen by the examiner, and lot of impressions are formed. So it's very important to keep this in mind while doing a cardiac examination. Wish you all the best. Thank you.